mucho mejor que español, así que voy a en este momento cambiar al inglés. Welcome everyone. Welcome Mateo. I'm really happy to have you here. It's really a dream having Mateo here and all the very good faculty that came from other hospitals. I would like to especially thank Virginia for the support and AstraZeneca as well for all the support and commitment with this academic activity that has no pharma bias. They don't know what we are going to say and we're going to show, and so we can speak freely here. But they bring Mateo and support us for this activity. So thank you so much. So the cases are going to be in English. Of course, if someone, I mean, English, language should not be a barrier. None of us here are native speaking in English. So if you feel more comfortable asking in Spanish, there is no problem at all. Make a comment or ask in Spanish, and we will get the message to eventually to Mateo. So don't be shy, and please, we encourage you to participate, because that's the goal of this meeting. So the cases are going to be presented by fellows or residents from different institutions, and there is a form that is if you can fill in the especially for the people coming from other institutions, in order to get the certificate of attendance, please fill in the form with your name and your email, and you will get it after the meeting. I will be coordinating the meeting, and I will be very strict with time in order to allow all the cases to be presented and discussed. So don't be upset with me if I cut the discussion abruptly. So this is the faculty that we have today. We have Mateo, Florencia Perazo, that is parking her car, and she's arriving soon. Cecilia Righi from Hospital Italiano, Laura and Federico Weinsberg, sorry, I didn't put you in the list, from Alexander Fleming, Ernesto Korbenfeld from the British Hospital, and Alejandro Kuzminin from Instituto Ángel Rojo. So thank you for being here. And we have a lot of in-house faculty. I apologize if someone of you is not in the list. I didn't know who would come or not. But we have basically most of the people that participate actively in the discussion every week, in patient discussion every week here in Hotel Alemán. Mateo is a friend, and he works in Genova. He's no doubt the global leader in breast cancer in young women. It's a very important academic personality, I think. Despite his age, he's really important, and he has been done a lot of contribution in this field of breast cancer in women. And he's also part and very active in ESMO. He's the director of Young ESMO, and he is a fan. He likes soccer a lot, and he's a fan of Sampdoria and of River Plate. So this is the agenda. We will have 15 minutes for each case. So that's it's going to be my task to on time. And after this, you are all invited to a lunch. Okay. So, and this activity is again endorsed, supported by AstraZeneca, I already said, and endorsed by the SUMA, which is the Argentinian Cooperative Research Group, and from the AOC, Asociación de Oncología Clínica. Okay, so now I invite Maximiliano Inc., which is president from Instituto Roffo, and Alejandro to the stage. Mateo, please, if you want to. Oh, we want to see the cases there, and then okay, we can do that. You present the case, and then we get in. Yeah. Or we share whatever.
Good morning, everybody. Thank you so much, first of all, for the opportunity to be here. My name is Maximiliano Inc. I'm a third-year resident in clinical oncology in Ángel Roffo Institute of Oncology. And in this opportunity, I'm going to be presenting to you a case of drug-induced pulmonary hypertension secondary to long-term treatment with lapatinib. The patient I'm presenting to you today is a female patient, 60 years of age. Those are her medical priors: depression, anxiety, hypothyroidism, and dermatomyositis, amongst others. The patient was diagnosed in July 2015 with a right mammarian nodule with pathological axillary nodes by ultrasound and mammography. That node was then biopsied, and the pathology report informed an invasive ductal carcinoma with a Nottingham score of 3, with no evidence of distant metastases by CT scans and bone scans. Afterwards, the patient underwent an upfront surgery with mastectomy and axillary lymphadenectomy. This, of course, would not have been our choice if we had met the patient in that time. This was performed outside of our hospital. We now know that in patients, especially in patients with HER2 positive and triple negative breast cancer, pathological complete response after neoadjuvant treatment is a very important factor, a prognostic factor for overall survival. So we would have chosen to give this patient neoadjuvant treatment. However, well, we received the patient after she had been operated on. The pathological report from this surgery informed an invasive breast carcinoma with an immunohistochemistry compatible with a hormone receptor negative HER2 positive disease with a Ki6740%. We received the patient in the hospital after she had been operated on, and in this circumstance, we decided to indicate adjuvant treatment based on chemotherapy plus HER2 blockade with trastuzumab for 1 year. She had a disease-free interval of 11 months, and in October 2016, via MRI, we discovered that the patient had bone recurrence. This was still during the treatment with adjuvant trastuzumab. So in this case, interpreting recurrence of disease recurrence, we decided to initiate first-line treatment with trastuzumab emtansine plus zoledronic acid based on the bone metastasis. She had a very short progression-free interval of only 3 months. And a couple of months later, in February 2017, a new image, a new CT scan showed progression of disease in bone by showing new lesions, especially in dorsal vertebrae. So interpreting bone progression, we decided to indicate a second-line treatment with lapatinib and trastuzumab, plus completing 2 years of zoledronic acid. This patient had an excellent response to this treatment. She continues with this line of treatment until present day, having maintained stable disease till now. And the case I'm going to present to you is based on a very unusual adverse event that we discovered with this patient. In September of 2023, in a routine echocardiogram that this patient was being performed, we found evidence of indirect signs of pulmonary hypertension with a pulmonary arterial systolic pressure of 47 millimeters of mercury, with previous echocardiograms showing normal values of this factor. associated with dilatation of atrial, right atrial and right ventricular ventricles, and moderate tricuspid insufficiency. The patient was evaluated for other causes that would explain this case. She had no evidence of pulmonary embolism or left heart disease or other plausible causes to explain this event. So, under the suspicion that this patient was exhibiting a drug-induced pulmonary hypertension case, we decided to suspend treatment with lapatinib and trastuzumab. The patient was carefully monitored in the following months, and in February 2024, she was performed a second echocardiogram, which showed a reversal of the disease with a spontaneous decrease of pulmonary arterial systolic pressure of 33 millimeters of mercury, and reversal of all the other signs that we had found in the previous study. This case was extensively discussed with the cardiology team in our hospital and in other hospitals, and the interpretation for this case was that the patient had underwent a case of drug-induced pulmonary arterial hypertension. After carefully discussing the patient and taking into consideration the excellent response that she had shown with the treatment with lapatinib and trastuzumab, taking into account also that the patient had remained asymptomatic during the course of this disease, we decided, in agreement with cardiology team, to resume treatment with second-line lapatinib plus trastuzumab, of course, maintaining a careful monitoring of the patient with the cardiology team and with close echocardiograms in case she developed once again symptoms or signs of pulmonary hypertension. Now, in the discussion, we would like to talk about, first of all, the interpretation of this case. In this case, we had a patient that had a long-term exposure to lapatinib that had no other causes to explain this case of pulmonary hypertension, and that we had a spontaneous decrease of echocardiogram values after the suspension of the treatment. This, of course, speaks in favor of a case of lapatinib-induced pulmonary hypertension. There is a few reports of patients that underwent this similar event with long-term treatment with lapatinib. There is a review of six cases of patients that were having treated with lapatinib that exhibited a similar outcome with increase in pulmonary arterial systolic pressure values in routine echocardiography, which then reverted spontaneously after the suspension of the disease. Unfortunately, we didn't perform a right heart catheterization in this patient due to economic access of the patient. That would have been ideal to confirm the diagnosis. However, based on the way that the disease reverted after suspension of the treatment, we are pretty confident that this is a drug-induced pulmonary hypertension case. Second of all, we find interesting in this case how the disease behaved to HER2 blockade. Let me remind you that this patient exhibited bone recurrence while receiving adjuvant treatment with trastuzumab, and then progressed again only after 3 months exposure to trastuzumab emtansine. However, after that, she maintained a stable disease during 7 years with second-line treatment of lapatinib and trastuzumab. That treatment was decided after the evidence provided by Blackwell's trial with trastuzumab-resistant HER2-positive breast cancers, who showed a benefit in disease in progression-free survival with patients who had a combination treatment of lapatinib plus trastuzumab versus lapatinib on its own. However, well, this is quite interesting for us to see how well the patient responded to this line of treatment. And finally, and this is a question for the audience to discuss, in the hypothetical situation in which the continuation of treatment with lapatinib and trastuzumab have been absolutely contraindicated in the onset of this adverse event, we would like to discuss which would have been the line of treatment that would have been best suited for this patient. This patient had not been exposed, for example, to trastuzumab deruxtecan, which today would be an ideal option as a second-line treatment for patients who had progressed with to trastuzumab HER2 blockade. And also considering the HER2 CLIMB study, there is also the possibility of initiating treatment with tucatinib plus capecitabine and trastuzumab, which also showed benefits in progression-free survival in patients who had already progressed to trastuzumab HER2 blockade. Well, that is all. Thank you very much.
Thank you for the presentation. We have a few minutes left for discussion. I don't know if you want to jump in the stage. I mean, so you can face the audience. I mean, I think it's more, it's nicer. I mean, I don't know. I don't know, but maybe you, whatever. I don't know. Yeah.
Hi, everyone. First of all, thanks a lot for having me. It's really a great pleasure and honor, and thanks also for coming, also from different institutions. I think it's a very nice idea to discuss cases, and this is something that I will try to implement also in my city. We have different hospitals, not a lot of chances to meet, so thanks for that. I just missed the Boca logo in the presentation, but it's okay.
What is
Next
that?
time, yeah. No, thanks also for the case. It's very nice. So personally, I've never had this toxicity, so I don't have any personal experience. But I have a young patient that is on treatment even more with lapatinib and capecitabine in that case for longer than what you have reported. So like my main probably comment or question is why to restart the treatment if she's maybe in complete response since 2017. So this is something that probably I would have considered based on the toxicity she had. And then for the third line therapy, I would definitely pick TDXT as preferred choice in this case, considering the lung toxicity she had. I would definitely talk to the pneumologist before starting the treatment, just to have some extra pulmonary test before starting the treatment. Normally, we don't do pulmonary testing in patients that will start TDXT, but in this case, you have some comorbidities where I prefer to have maybe a baseline test so that if anything happened during treatment, you have a baseline test to compare.
So thank you, Matteo. This is intended to be a very educational meeting. So we can discuss. You have a question.
I want to make a question. How long do you treat patients, for example, with HER2, for example, trastuzumab? We have a lot of patients in complete remissions for a long time. You stop?
It's a very difficult and critical question. I have a case of a patient that is in complete response with the Cleopatra regimen. It's now 6 years, probably between 6 and 7 years, that she wants to stop to have a pregnancy. And every time I say, okay, we will discuss in 4 or 5 months from now. So and then it's 2 years that I'm postponing that. So there is no proper answer on that. But this is something that is changing in the HER2 positive field, and then we will see the TDXT data in first line setting. I think we will have even more patients that will be potentially cured in the advanced setting. We may have this patient even more in the future. So this is a critical question. There are some attempts, some prospective studies trying to look into this question. So I'm not sure when the data will be reported. I think they've just started, so I think it will take some more time. But what I do in practice, normally I continue until the patient says, okay, I'm done. Yeah. So I'm not coming anymore to get the treatment. Otherwise, normally I continue. With TDXT, it's going to be different because TDXT is not pertuzumab, trastuzumab. So thinking about 5, 6, 7, 8 years, every 3 weeks with the treatment, well, it's different. So we will see that. And then maybe if I can just ask a question. So you didn't do a bone biopsy in this case because the behavior is very weird because she relapsed on trastuzumab, didn't respond at all to TDM1, which is still a good ADCs, and then she's having a very nice response to lapatinib and trastuzumab, which is nice, but not clinically very.
We don't make any biopsy after the progression in a bone biopsy. It's reasonable. but we don't make like a protocol in our institution to rebiopsy after other progression our patient.
In the case if she progresses again, I will probably consider.
Yes, in fact, to add to what Alejandro said, recently we had a suspicion of a new progression at bone level because she exhibited a CT scan with a very inspecific lesion in one of the coastal arches. It was quite inspecific, so we decided to monitor her again with a bone scan, which revealed a singular lesion that was associated with a previous traumatism that the patient had received in that area. So we discarded a new bone progression. However, we had discussed the opportunity to biopsy that lesion if it proved to be metastatic. We didn't do it before because we interpreted that having been receiving trastuzumab for 11 months and then TDM1, the pathological report that we may have received would not have been different for us. I mean, maybe she exhibited a negative HER2 in that report, but we would have discarded that based on all the blockade that she had been receiving.
Okay, thank you. Thank you for the presentation. Congratulations. Now, Juliana will present the case from CEMIC. I was saying this is intended to be a very educational discussion, so I will try. I will ask each participant to be as short as possible in order to encourage the participation of everyone.
Okay. And good afternoon, everybody. My name is Juliana Colucci. I'm a third-year resident at CEMIC. I'm going to present the next case, hormone receptor HER2 negative early breast cancer and pathological complete response. This is a case of a 30-year-old female patient with no personal history, neither family history of cancer, with no children, but with desire for parity. She detected a palpable breast nodule, a breast US, and a mammography were done, which evidence a suspicious nodule of 30 millimeters and also 4 suspicious ipsilateral axillary and also a retropectoral lymph node, PRAS 4B. A breast biopsy was done, which evidenced invasive ductal carcinoma grade 2, axillary and a retropectoral biopsy was done and evidenced metastasis from carcinoma, estrogen receptor 100%, progesterone receptor 20%, HER2 negative score 0, and Ki67 of 60%. She was also done a CT and bone scan that didn't evidence metastatic disease. So to sum up, she was diagnosed with a stage 3C, a T2 and 3M0 hormone receptor positive breast cancer. Genetic testing evidenced a BRCA2 mutation and fertility preservation was done. So first question, when dealing with a patient with a luminal B-like breast cancer subtype and BRCA2 mutation who will undergo a risk-reducing prophylactic bilateral mastectomy and also an axillary lymphadenectomy D2 and 3 lymph node involvement, taking into account that pathological complete response is not associated with a benefit in overall survival in this setting, what therapeutic strategy will you choose? Neoadjuvant treatment or surgery followed by adjuvant treatment? What do you think?
So basically, Flor, if you want to have the mic. So let me, because you were not at the introduction, Florencia Perazo is the attending.
Someone is talking there.
Yes,
Luminal B. Someone. Ernesto.
There are people connected virtually, so trying to speak.
I not completely agree with your phrase because in luminal B-like tumors, as the meta-analysis of Cortázar, there are a correlation between PCR and disease-free survival. There are a correlation not so clearly that in HER2 positive or triple negative, but there are a correlation in luminal B-like as the patient that you are presented with more than 60% of Ki67. For that reason, because of the stage, I would choose neoadjuvant chemotherapy.
Neoadjuvant, you say? Okay. It's the same thing that we thought in this case. So if you want to show the next slide. I don't know, Matteo, what do you
Yeah.
think about that?
Yeah, I will fully agree with the neoadjuvant approach. I think there it's where you want some downstaging, and then the response also will impact on the post-neoadjuvant treatment as well.
Exactly.
So I will definitely consider a neoadjuvant approach here.
That's why
We
our
agree
approach.
after discussion in a multidisciplinary team, she started neoadjuvant treatment with anthracyclines and cyclophosphamide dose for 4 cycles and was followed by weekly paclitaxel for 12 cycles. Surgery was done, a bilateral mastectomy, and axillary and retropectoral lymph node dissection, and pathology evidence pathological complete response with 0 lymph node involvement out of 12. So in this case, with a patient with a stage 3C breast cancer, luminal B, to achieve PCR after neoadjuvant therapy. First question, would you recommend radiotherapy to the tumor bed and lymphatic region, or someone would consider omitting radiotherapy, taking into account that she achieved PCR?
Alfredo, you want to make a comment? I don't know if you have any radiation oncologist.
One here.
Yes.
And he works in CEMIC
Yeah.
also. Dr. Andrade.
He's a very promiscuous radiation oncologist.
So a very nice case. I want to ask something about what you are just talking about before this. So I have a question for you, and then I'm going to tell you my opinion about this. My question for Matteo is, what happens if the same patient, instead of I mean, when we have a patient with this kind of tumors, if you can't downstage, for example, the axilla, or if you are not going to change your surgery, I mean, you are not going to change the mastectomy for a breast conserving therapy, if you always choose a neoadjuvant therapy.
Nowadays, neoadjuvant therapy will impact a lot the post-neoadjuvant treatment. So the access to different targeted agents that we have in the adjuvant setting, and the indication for some of these agents is also based on the response to the neoadjuvant therapy. So yes, in this case, I would have definitely considered a neoadjuvant approach.
I'm asking you this because when I was reading your case, and I saw that the same patients, you just make a lymphadenectomy, a lymph node dissection. So I was wondering what happened with the neoadjuvant. I mean, these patients have a complete response, and we just make the same surgery.
And on top of that, I think, I mean, she had a PCR, and she's BRCA2 mutated, I think. So she will, if we, that I think it's in the questions, no? But the fact that the patient got neoadjuvant chemotherapy put the patient in a situation, I mean, she's a 30-year-old, very risky patient, despite the fact that she has a PCR, she has a GH PCR. So if she were being treated differently with surgery upfront, probably she would be a candidate for adjuvant olaparib without discussion. So that's another argument. Maybe, I mean, if you don't change the surgery, I mean, do the surgery upfront. Okay. No, but what's your opinion regarding that?
You make questions in our case, a lot of questions.
No, yeah, I agree. That's what I was referring to. So the indication to some of these agents also depends on the treatment you are doing. But I think, to me, like before discussing the post-neoadjuvant therapy, I will go back to the case. This is a very high burden with a luminal B-like biology in a BRCA carrier, and we have data that Lumina-like tumor in BRCA carriers are biologically a bit more aggressive than lumina-like tumor outside the BRCA field. And so, I mean, despite the lumina-like biology and the high tumor burden, she had a pathologic complete response, which is something we see quite often in the clinic. So they are very sensitive to chemotherapy. So I'm very supportive on this choice. So
Okay.
it would have been more complicated if she had just one node, like 3 centimeter tumor, one positive node. This biology, then we can probably discuss a bit more. But in this case, I think it's
The radiotherapy, the answer of the radiotherapy.
The promiscuous radiation oncologist will answer the question.
I think that without any question, the indication of radiotherapy, it's valid. It's okay because the main purpose of this therapy is to local control, right? So I think maybe it would be at time of debate if we have a pathological complete response about the regions to treat, but the indications, for me, it's clear.
So you would
I would treat her.
irradiate her.
Yes, we have.
And you work at CEMIC, so we suppose that they do that. They did that.
I wasn't there that day.
Okay, let's go on. And would you consider ovarian function suppression, and for how long?
Okay, who gonna take the question?
Mateo.
I think Mateo knows a bit about that.
Yeah.
Okay.
Yeah, well, definitely yes. Definitely yes. In this case, well, the data are for 5 years, so I will try to go at least for 5 years. Now we have different extended adjuvant endocrine therapy trial in which they also extend the ovarian suppression beyond 5 years. Outside clinical trials, I'm not very keen to prolong OFS, so I do it only in patients with very, very high risk of recurrence, discussing that I don't have safety data to prolong beyond 5 years. But like in a case like that, I would definitely consider an extended adjuvant endocrine trial in which I also extend endocrine ovarian suppression as well. Then she's also BRCA carrier, so at some point, I mean, she's very young because she's 30, so okay, no, she's too young to consider all for it. So.
Yeah. Okay, any other comment from the audience? Any question? No?
Would you recommend adjuvant abemaciclib?
So, coming back to the hormonal therapy, would you use tamoxifen, aromatase inhibitors for how long? For the ovarian suppression is 5 years outside the clinical trial, and the hormonal therapy for how long would you recommend at this moment?
So the endocrine therapy, oral endocrine therapy, I will tend to go to 10 years in this case because she still, despite the PCR, she still has a high tumor burden and diagnosis, so she still qualifies as a high-risk patient. I would prefer AI versus tamoxifen again because
that's why I wanted to ask if you begin the treatment with EI, the suppression, ovarian suppression, and EI, no tamoxifen, because it's a high-risk patient with less than 35 years.
And after the first 5 years, you continue with tamoxifen.
Yeah,
in order to get
so here this is a very complicated scenario because we don't have data to extend endocrine therapy in patients that receive OFS plus AI in the first 5 years. So my boss will say, I stop it. I'm not very convinced because if
to stop at 5 years.
Me too, because if
in
you
this
give
kind of patient,
if you give OFS AI, you believe it's a high risk, so why you should stop at 5 years? You know, extended endocrine therapy works. So I will give tamoxifen alone unless there's a very high risk, which she doesn't qualify because she had a PCR, so it doesn't qualify for a super high risk to extend OFS. Now we have the adjuvant endocrine, we have different extended adjuvant endocrine trial open at our center in which we will extend OFS here, and I will definitely suggest this trial. So, we have it. So we have the Cambria 1 study. You can randomize the patient between 2 to 5 years, so you can sort of decide at which point you will extend the OFS. Yes, I would definitely suggest this trial.
Julie? Sorry.
In this discussion.
Sorry, so go ahead.
No, I was just saying that in this discussion, of course, the fertility part will also make an impact, because if she says,
In that.
So
Yes,
let's discuss just for a bit about abemaciclib. Would you consider abemaciclib?
yes, personally, I will consider she's a high risk and entry disease, biopsy in the nodes. So yes, I will definitely
I think
consider
there
it
is
for year.
no much discussion about that.
No doubt about that. I
mean,
think
now I'm getting a bit confused on the CG score for adjuvant olaparib in the hormone receptor positive cohort, because in theory she had entry disease, so if she was operated up front, definitely she will be eligible to olaparib, and in this case I would prefer olaparib to abemaciclib because she's a BRCA carrier. So
but you need to have 4 positive nodes in the
Yeah.
first time upfront surgery.
upfront surgery, yes.
In this case, with
No,
the adjuvant, it changed completely.
Yeah, it's this score which is very complicated to calculate. So all the time I take it. So I cannot tell you if she's eligible or not, because the PCR in the hormone receptor positive is different than the PCR in triple negative. So
But
in
it's
this
probably
case,
not.
I think
It's
she's
probably
not
not
eligible,
eligible.
but that I will check with the calculator before say. So if she's not eligible to olaparib, definitely yes, abema. If she's eligible to olaparib, I would choose in a BRCA carriers, I would prefer olaparib.
Another question. Is there any situation in which would you recommend adding carboplatin to for a patient with a luminal breast cancer?
It's a difficult question. In this case, I would probably have added carboplatin without a lot of evidence. So I'm not saying it's good, because you don't have the evidence to support what I'm saying, but I treat a lot of young patients. And in this case, I prefer to maybe over-treat a bit if there is a high tumor burden in this case. I'm not saying that I over-treat young patient, because you should not over-treat based on age, but she's 30 with a very, very high tumor burden, so I will have probably added also carboplatin. Then with a PCR with your regimen, I will have been wrong to do that, because it was perfect like that. But if you have a T2 and 3 30-year-old lady, BRCA carriers, I will try as much as I can. So yes, I will have added it.
Thank you, Matteo.
What do you consider the most optimal method for fertility preservation, and when would be the best time to plan?
So we don't have time, but because of it's you will have time to answer the question.
Okay, thanks. I'll try to be brief, but it is the most complicated case to discuss the fertility part, because it's a luminal-like tumor, very high tumor burden, BRCA carrier. So I cannot even say you go for ovarian tissue cryopreservation, so you don't stimulate. You don't do it. So you have to do the counseling. You have to propose oocyte or embryo cryopreservation. So for us, it's oocyte only, because in Italy, embryo cannot be cryopreserved in patient with cancer. So it will be oocyte cryopreservation. But yeah, in the first 5 years, I will not stop the treatment. So if she comes and says, I've seen the positive trial results, can I stop the treatment? I will discuss with her that I don't feel she should, because the node positive patient, and particularly N2, so more than four positive nodes in positive, were like 25 patients in total. 1 out of 4 had a relapse within the short follow-up of the trial. To me, it's not because of the pregnancy. We have a lot of data that pregnancy may be even protective, so it's not the pregnancy the trigger for the recurrence. Probably not even the interruption of endocrine therapy, but she has a high risk of recurrence, particularly in the first few years after diagnosis. So that's why I would prefer to do at least 5 years of endocrine therapy before stopping. And she's very young, so she can wait up to 35 years of age. She's not 42.
Excellent. We don't have more time.
Only one. You will do ovarian function suppression during chemotherapy with patients?
Yes. Also to avoid the issues, to decide the ovarian, so to understand if she's in chemotherapy-induced amenorrhea, is she postmenopausal, yes or no? Okay. She's 30, so for sure she's not in permanent amenorrhea, but but yes, I do
Yes,
it every.
Thank you,
Thank
Gonzalo.
you. Thank you. Rofo, stick with the time, and you know. So thank you very much.
Congratulations.
So now the next case comes from, I don't know, Hospital Italiano. Florencia will present it.
It's gonna be in Italian after Giuliana Colucci, which is very Italian. The first name and second name, Ospedale Italiano. And
I wish Italian. It's really not. Okay, so thank you for having us. Good afternoon to everyone. My name is Florencia Gallo. I'm a breast surgeon. I'm not an oncologist, so I'm very sorry that you're going to listen to me right now. But our clinical case is the following. She is a 39-year-old female who presented in November 2014. At the moment, she was premenopausal with a small palpable lump in her right breast. She had a specific gynecological history of 1 pregnancy and 1 miscarriage the year prior to her diagnosis. During that same year, she had 4 fertility treatments. 1 of them was an IVF. The other 3 were IUIs. All of them had ovarian stimulation. And her family history was an uncle with prostate cancer at 80 and a grandfather with esophageal cancer at 70. And at that moment, we performed imaging studies. The nodule was not visible on mammogram, and by ultrasound, you could see a 12-millimeter solid mass in the lower outer quadrant of the right breast, categorized by REDS 4. It was not visible on mammogram. So we performed a ultrasound-guided cord needle biopsy, and that revealed the presence of an invasive breast cancer, which was a luminal B phenotype. It was 7 crosses of estrogen receptor, 8 progesterone. HER2 was equivocal, and by FISH it was negative, and then a Ki-67 of 20%. Okay, so at that point, since it was a stage 1 tumor, we decided to go with a lumpectomy plus a sentinel node biopsy, and surgery revealed an invasive breast cancer, G2, 7 millimeters in size, and 0 of 2 sentinel nodes, with none of them with metastasis. And the immunophenotype was again maximum expression of ER and PR. HER2 was negative, and Ki-67 was 20%. So at that point, our first question was whether to ask for that patient to do a genomic assay. I think probably everyone in the auditorium would agree with having a genomic assay in that setting. So we did. We ordered an oncotype, and the recurrence score was 13. So we considered her a low-risk patient, and she went on to do radiation therapy. She started after radiation with tamoxifen, which she took during 5 years, and initiated ovarian function suppression. She discontinued that 3 months after because she was very, very intolerant to this, and there were a lot of symptoms. She had really, really bad tolerance, and so she decided to discontinue it, and she went on with tamoxifen and completed the 5 years. And at that point, we recommended genetic counseling, and the only things that were studied at that moment were BRCA1 and BRCA2, and both were negative. So after 5 years, the decision was whether to extend or not her adjuvant endocrine therapy. She decided that she was not interested in going on with that endocrine therapy because she had pretty poor tolerance and had already tolerated 5 years, and so she was not willing to continue. And after 2022, she was 8 years into progression-free survival, and we decided to extend her genetic testing. And so we did a genetic panel, and we found a variant of uncertain significance in PALB2. So at that point, we have in 2023 a patient who is now 47 years old, 8 years, 9 years into follow-up with a progression-free survival. And at that moment, she finds a new lump on her right breast, and the same breast that had been previously treated. It was not visible on mammography, and she had a new ultrasound, which confirmed the presence of a 9-millimeter mass at the 8 o'clock position of the right breast. So we did core needle biopsy. It was once again invasive breast cancer with a very similar immunohistochemistry. And we ordered staging studies, and we found a CT scan that confirmed the presence of a solid lung nodule with spiculated edges in the posterior basal lobe of the left lung, measuring approximately 13 millimeters. And on the PET scan, this had increased metabolism and a standard uptake value of 5.2. Okay, so at that point, we tried to biopsy every lesion, especially the first progression. So at this point, we did biopsy, and the biopsy confirmed that the lung had a breast metastasis. The immunohistochemistry was identical to the one on the breast tumor. So since she was going to have to initiate treatment with AI, what she did was what she did was a bilateral salpingo-oophorectomy. And at that point, what we found in the pathology was a borderline tumor, a clear cell borderline tumor with 2 millimeters of invasion. It was discussed in the tumor board whether that would be taken into consideration for treatment at the moment, which was decided to go into surveillance and to prioritize the treatment of the metastatic breast cancer. And so she started treatment with letrozole and ribociclib. In September 2023, 4 months after she started treatment, she did new imaging studies, and these new imaging studies proved that the nodule on the lung had no longer the same standard uptake value. It was now a value of 1, and she had poor tolerance to the dose of ribociclib that she was using, so there was a reduction in dose. She was starting to take 200 milligrams instead of 400 because she had already had a previous reduction in dose because of neutropenia. And in October, in lab tests, we discovered hepatotoxicity. She had GPTs and GOT that were multiplied by 10 to 15. So ribociclib at that point was discontinued. And what we had to consider at that point was whether or not to later re-challenge her when her liver function test normalized, or to change her CDK inhibitor. The decision was made to change the CDK inhibitor, and so she started with letrozole and abemaciclib with full dose, and the truth is that she has much better tolerance to abemaciclib, and she normalized her liver function tests. Currently, she has a PET that is stable, and her treatment is very well underway and tolerated. So at this point, the question, and this is where we're opening up for discussion, is whether we should start taking into consideration the possibility of local treatment, either for the breast or for the breast and the lung, or just for the lung, which could be local regional treatment as SBRT or surgery or whatever the option might be more appropriate. Thank you.
Thank you. Thank you, Flor. Well, we might stay back a little bit and discuss the use of genetic platforms in premenopausal small node-negative tumors. You wanna? I don't know if someone want to make another question. If there is another question, I would like to hear what Matteo think about that.
Yes, we work in a public health system, so we have access to genomic testing, but there should be certain criteria to ask for the testing. So in this case, I'm not using genomic testing in premenopausal women with node-positive disease, because to me they just complicate the discussion, and so normally we don't ask in premenopausal node-positive. Of course, in postmenopausal 1 to 3 nodes, yes. In the node negative, we do when there is indication to ask for the testing. In this case, I was waiting for your for what you have done in your case. Yeah, I would probably have asked the genomic testing for the 20% KICC7. If it was the other tumor with a 14% KICC7, probably I would not have asked for the genomic testing. The T1B and 0 is still a T1B and 0 tumor. So if you trust your pathologist, breast pathologist, and I mean it's a 10% KICC7, I will not ask for a genomic testing there.
With a really low risk for by KI67 grade 1, you would not.
That case, no.
Do it.
And the same if it's a high risk that you feel that is.
But in this case, you feel
Yeah,
it's
the
okay.
20% KICC7, you don't really know what it's.
And which platform would you prefer?
We have Oncotype DX only.
Do you think that any other platform would be?
So the best
Yes.
evidence is with Oncotype DX, and it's the only one that actually prospectively studied the possibility to avoid chemotherapy for the intermediate risk group. So, I mean, if you have other platform in-house that will cost less, definitely yes. In our case, we have only one test it's reimbursed, which is the Oncotype DX, so we are obliged to ask for that.
Yes, I just wanted to make a comment regarding of the platform. the oncotype. This patient has another risk factor that she is a physician in our hospital. So
I definitely agree. It's a negative prognostic factor. Yes.
So she was very well informed, and she was she agreed to perform the oncotype DX. Besides, maybe she was young.
Can I also make a comment on the endocrine therapy that I'm fully aligned with what you have done. So I will have discussed OFS with tamoxifen in this case, intermediate risk, intermediate low risk. But if she doesn't tolerate it, it's not a big deal. In this case, T1B and 0, and then on the top is a low genomic risk. So
It
I
was
fully agree.
discussed and they decided to start it, and it
So
was
this
suspended.
was the question. So the ovarian suppression, you consider ovarian suppression for intermediate patient, intermediate risk patient. If she would had a lower risk tumor, like grade 1, low Ki67, tamoxifen alone.
Grade 1, and she has a T1B and 0 tumor. If she had a grade 1 tumor, definitely tamoxifen alone, not even discussing other parameter. I'm not using the genomic testing to decide the endocrine therapy, because this is something we are starting to do, but there is no evidence.
And the duration OS 2 years according to the Astra.
Yeah, in this case, the first side effect after 2 years, I will definitely stop it. But yeah, normally go for 5 years, but this is a case in where you can discuss that 2 years is probably.
It's okay. It's probably okay.
Yeah.
Cool. So we so continue with the case. I think there is no much discussion about the role of the biopsy. Everyone agrees that no. We all agree that biopsy was necessary with less ribosiclib. I think everyone agreed. So re-challenge with Rivo or yes.
With a re-challenge. Why not to re-challenge with ribociclib? Less dose, 400.
But she was already on 200, so she was at the lowest level and she had a grade 3 toxicity.
She started at 600 and she had poor tolerance and she had several episodes of neutropenia. So she had already had a risk reduction to 400 and then she had a risk reduction to 200. So she was at the minimum dose. She had toxicity.
She had the hepatotoxicity with the 400 dose. Yeah. So at that moment, we think, well, 200 with the risk to repeat the adverse event or to change to abemaciclib, full dose.
100, because it will not be sure that it will work. With 400, yes. And perhaps the AMELI does not show the inferior criteria, but we can do it. But with 200, you don't have any evidence to do it.
So we decided to.
No, not okay. I didn't understand before that. Sorry.
Cool. Okay, so we continue. We have 3 minutes. So with this, the most difficult question regarding the oligometastasis thing. What?
Last to the radiation oncologist.
So let me just tell you what we would do in this case here at the hospital. We probably would treat that metastasis after 6 months of CDK4/6 inhibitors and AI. I mean, there is no evidence supporting the local treatment of oligometastasis, but we would at least discuss with her. We have several patients in that situations treated locally in the breast and in the metastasis after time on CDK4/6 inhibitor.
I agree. The evidence is not there. So if you look at the evidence, the answer is no. We go for the first line therapy. We don't do any local treatment, but I also have cases, as you have mentioned, like this case. What has happened recently is a similar case with that after 2 years on CDK4/6 inhibitor, and we didn't do any local treatment. She had a local progression in the breast only. So that was the time in which we decided to go for the local treatment in the breast. But in this case, I agree that I will consider a local treatment. Yes, if you go for a potential radical approach, I will go for a radical approach. So
She has a complete dispersion of it's gone. The lesion has disappeared completely with treatment, so now she can do both.
yeah, I don't know, for the 6 months, I think this is something I will discuss. So I will probably go a bit longer than 6 months, just to be sure that, yes, she's a patient responding well on treatment, doing well on treatment, that you don't have the feeling that the disease is going somewhere else. So in that case, then I will consider probably the local treatment.
And what would you do for the lung lesion? Radiotherapy like SBRT or
I will do
surgery?
SBRT, yeah. SBRT, I don't know if I'm not the right person to answer this question, but I will do SBRT if feasible, yeah. Yeah, definitely. Definitely.
If it's a safe place, or maybe surgery, or maybe another option of ablative treatment in oligometastatic patients is the great option, right?
Okay, great. Any other question, comment, Mateo? Anything else?
No, I have the comment. I'm a thoracic surgeon, so I must
Sorry about it.
I must comment on this, right? Like, no, I think that this, so this usually the multidisciplinary tumor board is always the right answer, because I don't think that, I don't know, maybe the breast surgeon should choose whether to radiotherapy or surgery, right? Like, you have to ask the thoracic surgeon and the radiologist guys, what are the pros and cons of each of these approaches, right? So I think that to that questions is always just have the discussion, right, with the specialists.
Definitely agree.
Yes. Okay, thank you so much.
Thank you.
Thank you for the case. So the next case comes from Instituto Alexander Fleming from Buenos Aires, and it will be presented by Laura Lapuceschi in English, not in Italian. She wanted to present it in Italian. Yes, I know.
Good afternoon. My name is Laura Lapuceschi of Alexander Fleming Institute. Matteo, piacere per me, per tutti noi, che tu sia qui in Argentina. I'm going to present this case, female patients with triple negative early breast cancer after pregnancy, BRCA1. I know conflict of interest. She is 65 years old. In her family history, her mother has an ovarian cancer, diagnosis at 60 years old, and in her personal history, she has had 2 pregnancies. The last delivery was 7 months before the diagnosis of breast cancer. In April 2021, in the context of breastfeeding, she consulted for self-palpation of a mass in the right breast. In the physical examinations, reveals in the right breast upper outer quadrant a mass of 2.5 centimeters, and in the left axillary, nose of 3 centimeters. The biopsy reveals in the right breast invasive carcinoma, estrogen receptor 0, progesterone receptor 2%, HER2 0, and Ki 67-40%. And in the contralateral axillary, metastasis of breast cancer triple negative. The study of extension was negative for cis. And the question is, what is the next step? Surgery up front or neoadjuvant chemotherapy is considered this is a metastatic disease, and you consider a first line. What scheme, and if you use or not gonadotropin antagonist. In this case, the neoadjuvant chemotherapy was the choice. She underwent OC preservation, and the genetic counseling was requested. She started with boserelin, and the first phase with docetaxel plus carboplatin for 4 cycles. She received the genetic test with BRCA1 mutation. And next is continue with doxorubicin plus cyclophosphamide, dose 10 for 4 cycles. I don't know, you need stop here or continue?
Your English is really good.
Yeah, you're doing great.
So everything, we understand everything. Yes, we can stop here and discuss. So everyone, is there anyone here that would have opted for upfront surgery? I don't know the surgeons, if you want to make any comment. Yeah. Okay, so we all agree that we would have treated the patient in the same way. Fede, you want to make any comment?
Yeah, one of the first discussions we want to make is if we consider this patient to have an advanced disease or a localized disease. I know, or we know that contralateral axillary metastasis is a very infrequent event and also usually associated with prior surgery in the breast or in the axilla or mediastinum treatment. I'm sorry.
Go ahead. And then.
And we maybe chose to be over-optimistic and treat this patient as if she had a bilateral breast cancer.
Yeah,
So,
what did you consider to do an, I don't know, MRI to look for the other?
yeah, we interpreted the case as giving her the most favorable treatment approach, considering that she had a occult right cancer synchronous to her left cancer that, as Laura said.
So, Matteo?
It's also my question on the contralateral breast. Maybe it's not an axillary positive nodes on the so the left nodes on the right breast cancer, or maybe is a TAP syndrome on the other side. She's a BRCA mutated patient. So with this doubt in mind, I agree with the potential curative approach, which is completely negative on other sides. So the staging is negative outside the axilla in the breast. I agree that with this doubt in mind, I will go for the curative approach. This was to 2021, so before the keynote regimen. So right now we'll treat her with the keynote regimen. Otherwise, I fully agree with it. And I like a lot that you use a lot of dose dense chemotherapy.
Yes.
So the high risk case, lumina-like disease, which is something in my country we were not doing before the availability of the more recent data, but now we definitely do dose dense in the high risk patients. So yeah, I like that.
Laura, go ahead.
The pre-surgical studies were negative with the sonography, mammography, and MRI. Now, what type of surgical approach would you have recommended? Breast conservative surgery or bilateral mastectomy? In this case, she decides the bilateral mastectomy. What would be the optimal axillary management? Bilateral lymphadenectomy or bilateral sentinel lymph node? Or bilateral lymphadenectomy plus right sentinel lymph node biopsy? The last choice was chosen. And bilateral salpingo-forectomy, when? In this moment or not?
Alfredo or any of the breast surgeons want to take the question?
So I should choose the same surgery, but it's important to say that in San Antonio in December presents a very large trial of 4,000 patients with the same mutation, in which they demonstrate that breast conserving surgery or bilateral mastectomy is the same in overall survival. So it's the same for us.
Yes, but in this particular case, where an possible hidden tumor was, I mean, for this particular case, I think the conservative surgery is not a good option.
It's not correct. Yes, of course. We can talk about the sentinel lymph node or lymph node dissection on the contralateral axillary. I don't know if left or right. I'm losing. I mean, I'm sure about the lymph node, the sentinel in the same breast that you have the tumor, and I'm sure about the lymph node dissection in the other side. left. I don't know.
Yes, yes.
Left
I
side.
was, so I'm agree.
So you
that.
you would have done the same, not bilateral sentinel lymph node biopsy.
Well, here we are in 2021. So maybe here we can do a sentinel lymph node dissection and the resection of the other node that was biopsy in.
So you clipped
before the neoadjuvant setting
from the lymph node,
Yes,
and
of
then
course. Yes,
you-
I will do that instead of
at
a lymph node
this
dissection.
moment, not at the moment the patient was treated. Okay.
No, 2021 too. I will do the same thing too.
So here she would have a bilateral sentinel lymph node biopsy and not lymphadenectomy in the left side.
Yes, of course. But I should take out the other node.
Yes, correct. Matteo, anything to add to that?
On the breast surgery, in this specific case, I will discuss the bilateral mastectomy as my favorite approach, but for BRCA carriers, when we discuss the risk-reducing surgery, it's different the discussion for the salpingo-oophorectomy versus mastectomy. Mastectomy is not something that the patient should do. It's something you discuss with the patient, so it's a shared decision. The bilateral salpingo-oophorectomy is pretty clear that in this case, between the age of 35 to 40 years, she should receive bilateral oophorectomy. When to have it, it depends also on her pregnancy desire, family desire, and so on. So probably I will not do at 35 right away, but I will start talking to her that within the next 5 years, she should receive a bilateral salpingo oophorectomy. We have this large BRCA cohort, and we should report in San Antonio the data on the risk-reducing surgery in this cohort of almost 5,000 cases, and thanks also to all the Argentinian centers that are participating now and will send the data for San Antonio this year. What we see is that if a patient is diagnosed at a young age with breast cancer, the risk of another tumor is higher than if you are being diagnosed at 50 or 60 years of age. So this is why I'm a bit more aggressive in this counseling with young patient with breast cancer for subsequent surgery later on. But I will not do it right away, which is something that sometimes happen, that there are these patients, maybe even younger than 35. It happened to a colleague of mine a few years ago that the gynecologist wanted to remove the ovaries because after 6 months following chemotherapy, she still had chemotherapy-induced amenorrhea. So she said, okay, you are in menopause and then it's you are a BRCA carrier, so we remove it now. And I said, please, no. I mean, she's super young. She doesn't need to get into menopause at 33, and the menses will come back at some point, and they came back. Now she's almost 40 and she doesn't want to get the surgery, so it's another problem. But but in theory, she should by the age of 40. I will not rush to have the surgery right away, but she should be in the mindset that before the age of 40, it's better she removes the ovaries.
She realized the bilateral salpingo-oophorectomy in the same time of bilateral mastectomy without disease. And the pathology result was in the right breast, pathologic complete response, and the sentinel lymph node biopsy negative. And in the left breast, no evidence of disease, and the lymphadenectomy shows 0 to 13, 2 with changed due treatment. Now, adjuvant treatment, now in the context of use of neoadjuvant keynote, pembrolizumab, but no in this case. If residual disease, capecitabine or olaparib, for the progesterone 2%, hormone therapy. Radiotherapy, in this case, she received radiotherapy 3D in the left axillary level 3 and supraclavicular lymph nodes. Any comments about this?
Yes. So now the adjuvant treatment. I mean, she didn't got pembrolizumab in the neoadjuvant phase, so probably there is no place for adjuvant immune therapy in this situation. We have the Alessandra trial published in San Antonio showing no benefit of adding atezolizumab in situations like this one, no? So and I don't know if you want to make any comment about that.
No, yeah, I will not. She didn't receive it neoadjuvantly, so I will not give it now. She had also a PCR, so I will not give it now. If she received Pembro in the neoadjuvant setting, now she has a PCR, what to do afterwards? In theory, based on the trial, you should also give the Pembro in the adjuvant setting, but if she had any toxicity in the neoadjuvant phase, any immune-related toxicity, I will not give it in the adjuvant setting. So
it means that you're not very convinced of the role of the adjuvant pembrolizumab in.
I'm not very convinced that you need to give it in the. So I would love to participate to the Dana-Farber trial in which they are actually randomizing to not give it in the adjuvant setting versus not. Just to add at ASCO, there will be this year the presentation of the ABRAVE trial, which is the Italian study on avelumab in the adjuvant setting for patients without a PCR that didn't receive immunotherapy in the early setting. So it's the first post-neoadjuvant immunotherapy trial to be presented. So there will be data soon, but I will not keep it.
I wanted to ask in the case if the patient if the patient had a residual disease and the combination of pembrolizumab and olaparib wasn't covered by insurance, which drug would you have chosen?
Olaparib, BRCA carriers, olaparib, yeah, definitely. And in this case, between capecitabine and olaparib in a BRCA carrier, I think there is no choice. For us, in the public health system, we cannot combine capecitabine with Pembro nor olaparib with Pembro, so we have to decide what to do. And if there is a high disease burden after a neoadjuvant treatment, I will probably go more for capecitabine than for Pembro in this case. I would love to do it together because there is no clinical or any reason for not combining them, apart the fact that we don't have the evidence on the efficacy of this combination, but yeah, we cannot do it.
Clarification, Alessandra, is not for neoadjuvant patients. They didn't get it's their upfront surgery. Yes. So for the 2% of progesterone receptor expression, I think
I will not
use. Let's discuss maybe if this patient would have 9% of estrogen receptor.
12%. It's even more complicated. I mean, the endocrine therapy in this poor lady will be super, super toxic. For which benefit? With a 9% ER and maybe PR negative in a BRCA carrier, where you have the data that the luminal tumor. So
let's imagine
in a 9% ER, I will discuss it, saying that me myself, I will not take it.
Okay. Let's imagine that she's not BRCA mutated, and she has residual disease with ER low, which is a situation that we sometimes see and face every day. So
I would probably discuss it a bit more than the BRCA carriers, but I'm not very convinced.
This
now we have
benefit is quite low, right?
Yeah, now we have more evidence that also the biological behavior of these ER low tumors is more in line with a triple negative disease than the luminal-like tumor, and also the benefit of endocrine therapy is very, very low. If it's 9% estrogen receptor, I will discuss it, yes, but I'm not very convinced. I mean, we'll give it OFS AI 5 years for maybe, I don't know, 1% benefit, a super, even probably less than 1%, a super toxic.
So you discuss, but you are not convinced. Yeah. I mean, you mentioned it, and
if it's more than 10%, yes, I do it, even though it's 12% zero progesterone, I would still be in doubt on the benefit, but then I will discuss it.
Good.
In summary, 35 years old, BRCA1 mutation in May 2021, triple negative breast cancer without distant lesion. She received neoadjuvant chemotherapy, bilateral mastectomy with pathologic complete response, salpingoforectomy, and radiotherapy. Now, what is your recommendation for follow-up?
We are out of time, so let's go quick through the questions. So how do you follow up this patient, Matteo?
We are not. We try to stick to the guidelines, so we are not doing an aggressive follow-up or intense follow-up because there is no evidence, and so we try to stick to the guidelines for the follow-up. this is a particular case because you are still in doubt if she had a metastatic disease diagnosis or she had a bilateral breast cancer or a CAP syndrome and breast cancer on one side. So probably after a year, I will do a CT scan, yes, or a PET scan. I will do it after a year. Maybe in the first couple of years, I will do it, but normally I don't.
Honestly, here we would be much more aggressive in this particular case.
At the European Institute of Oncology, they do a very aggressive follow-up. So every time we see, it's very close to Genoa, so we see a lot of patients from one hospital to the other. Personally, I don't agree because we don't have evidence. But then, of course, we have different cases. This is a case where I would definitely consider a more aggressive follow-up.
Yes, in this
For
case,
the ovarian cancer, for the risk of ovarian cancer, I will stop doing anything because she did a salpingo-forectomy,
Yes.
so I will just do a gynecological examination once in a while, but I will not do any special follow-up.
okay. In this case, the last CT was in November 2023 without disease, and the ultrasound in the right axillary and level 1, 2 lymph nodes with cortical thickening by RAD3. The next control will be in May.
Okay, thank you so much, Laura. So the next case comes from the British hospital and is going to be presented by Maximiliano, no? Felix.
Hi, good morning. My name is Felix Urtasun. I'm resident of oncology clinical of British Hospital. I present a case clinic of female of 33 years old, don't have any antecedent familiar and personal. This patient feed a nodule in the breast right of 5 to 5 millimeters. In the mammography, don't evidence any BRAD 0, and the ultrasound is BRAD 4. In the magnetic resonance, 12 to 12 millimeters mass like enhancement. And in the biopsy, invasive carcinoma, nose, histologic grade 3, endos M1, estrogen receptor 95, progesterone receptor 1, KI 67.4, 40% HER2 negative, and the CT scan and bone scan seen no evidence of metastasis. In the lumpectomy, infiltrating carcinoma, histologic grade 3, tumor size 9 to 9 millimeters, negative margins, estrogen receptors 100, progesterone receptors 1%, KI 67, 35%, HER2 negative, and the sentinel lymph node biopsy, absence of metastasis. The question from Mateo on the public is, what course of action would you take?
So yeah, go ahead.
You mean in terms of deciding the systemic treatment at this point?
Yes.
So this goes back also to the genomic test.
The patient and the...
Yeah, also to the discussion of the genomic testing to decide if you give or not.
How old is she?
33.
In this case, I will ask for a genomic testing. It's very likely it's going to be high risk because of progesterone negative and quite high Ki67, but before deciding to give, it's a T1B and 0 tumor. So before giving chemotherapy, I will ask for a genomic testing.
Okay. Oncotype and genetic counseling. The oncotype 32%, and in the genetic counseling, no pathogenic variants detected. And the patient go to fertility preservation counseling. The patient opted for oocyte vitrification, contraception counseling, and psychological oncology consultation. About the adjuvant therapy.
No, Felix, stepping back a bit, I would like to know Mateo's opinion and other faculty's opinion regarding the use, what we were discussing, and we so the access to platforms here are difficult in this country, because they most of the time they have to pay out of the pocket for the Oncotype DX, and it's expensive, and with the economic situation of the country. So I mean, it's difficult. So the vast majority of patients that we would like to have a platform, we don't get it, and because of that, we were discussing the use of Ki-67 kinetics, the adapt strategy, in order to select better, I mean, to have an extra or an additional biomarker in order to take decisions. What do you think about that?
Yeah, this is a good point. We also discussed after the presentation at ESMO, I think it was last year or a year and a half ago, to potentially change the practice there. We have not done that yet, so we are not using the adapt cycle approach, but it makes sense. Yes, you have the evidence, and then while she waits for surgery, you can do a month of endocrine therapy. So I agree that this could be helpful if you don't have the access to genomic testing. Otherwise, in this case, I will do surgery without complicating more the biology of the disease. I will do surgery first and then the Oncotype DX later.
Okay, any insight from the other faculties or audience? Okay, so let's go ahead. Thank you. Sorry, I interrupted you. Okay, we will take the first. Which regimen? If it is anthracycline-free or anthracycline-based chemotherapy, I guess it's the first decision that we have to make.
I don't know what you think. Me personally, I would give a TC regimen. It's a T1B and 0 tumor, so despite the high genomic risk, has a low clinical risk. So I will go for the TC regimen. What I discussed with the patient is the optimal is 6 cycles, because it's the one it's non-inferior to anthracycline-based therapy. But then if she has a lot of toxicities, in this case, again, T1B and 0, I will stop at 4 cycles.
Okay, we would have. I mean, we have the same approach. For this case, we probably avoid anthracyclines, and we intend to give 6 cycles of TC, but we don't bother if we stop at 4.
Scalp cool.
Yeah.
With the scalp cooling, I see it upstairs.
With scalp cooling, yes, that's another thing that patients need to pay out of the pocket. So it's not for everyone. What they do here is they do their own cold cap, like manually, and they freeze the caps, and they brought the caps within refrigerator, like a beach refrigerator, for camping, and they camp at the heavy infusion area, cooling their head.
Does it work? Does it work?
I mean, yes. Yes.
That's.
It's a patient of our hospital who began with this kind of scoop. Yes, and he's local caps, Argentinian caps, and they are very good, and there are a lot of people using that, and with results. Perhaps sometimes they are good. They are, yes, 50.
This is interesting. Huh? I mean, the concept is the same. So
yes, I mean, it's the same. What they do is the caps are freezed. They take these gel pads, for the knee or and they stick the every 15 minutes. Yeah. Yes. The logistic is quite complicated, but I mean, it's feasible, and the efficacy is pretty much the same of the.
And for us, we have a public health system, and it's not covered the scalp cooling, but so not all the hospital can offer it. I mean, if you are in a large institution, normally there are foundations or patient advocacy group that will give you for free the machine, and then so that's why it's covered in some hospitals, but it's not the public health system, so it's also not covered in my count.
So we haven't discussed the hormone therapy question. So what do you think? I don't know if someone wanna take the question. Matteo?
Yes, I will go for OFS for sure. Endocrine therapy, yes. Ovarian function suppression, definitely I will consider it. Tamoxifen versus AI, I'm more in doubt in this case. I will consider if you look at the Regal risk score, so the composite risk score based on the clinical pathological features, probably she will fit into the intermediate risk group. So in the intermediate risk group, if you give chemotherapy, probably there is no big difference between tamoxifen and AI. If you don't give chemotherapy, better you give AI versus tamoxifen. So on the top of OFS, to me, it's the same to go for AI. Tamoxifen, I will probably start the AI, telling the patient if you have big side effects, we can switch to tamoxifen without big problems. So.
A practical question regarding OS. If you start OS with chemo concomitantly in order to avoid or prevent,
which is what I do in most
of the time,
menopausal patient.
Do you stop the OS after chemo, or you continue right away for the 5 years?
Continue right away. And one of the reasons more than the fertility part or the ovarian preservation part, I do it also for the endocrine therapy. So makes my life easier and also the patient life easier to just continue instead of maybe going into those months in which you check the estradiol level, you don't know. So I normally do it and I continue.
And another, I asking questions that are practical questions that may I think are helpful for everyone. So in the case that she would have exemestane, or an AstraZeneca, in this case, would you check regularly the estrogen levels?
Yes, in the first years I will check it at least 2-3 times, probably 3 times in the first year. Then if you are okay, then in the following year, maybe I do it once or twice a year when she has a blood test for also other reason. But in the first year, I will do it. Okay. And especially the younger the patient, the more likely she may not be completely suppressed. So
and let's imagine the patient is 45, and is so we expect. The likelihood of having an induced menopause is much higher. In that case, you would consider stopping OS after chemo and see if the cycle resumes, or you stick with the monthly or conservative.
So in that case, maybe you can discuss not to have OFS during chemo, because OFS during chemo, in theory, you give it for preserving in the long term the ovarian function. So you say, okay, this patient is close to the age at menopause, so I don't need the preservation part. So but 45, I still discuss also the use during chemotherapy for potential like preservation in the long term. But in this case, 48-year-old lady, I think this is more complicated. If she has a very, very high risk of recurrence, I still start OFS before chemo, so I continue OFS later on and give AI at the end of chemotherapy. Otherwise, if she doesn't have this high risk, I don't give anything during chemotherapy. Then when she finishes chemotherapy, I give tamoxifen alone, and then I start maybe checking the estradiol level in the following months. And then if she resumes ovarian function, I will start OFS at that point. In this specific situation, I always write in the notes the contraception counseling you have mentioned. I think it's critical because a lot of these people, maybe 48-year-old lady, receive chemotherapy and now she's on tamoxifen. She feels to be she feels to be in menopause. But then I write that also the absence of menses and the use of tamoxifen are not criteria for defining a permanent menopause in this case. So she needs a non-hormonal based contraception, because you can get pregnant without menses on tamoxifen with just some ovarian function, and tamoxifen is teratogenic. So I also write that in the notes. So
So that's a critical point.
Gonzalo?
Okay, I don't know,
brief
Ernesto,
comment, only a
let
brief
me
comment.
let me give you the
We chosen this easy clinical case to remark two things. One is the importance to work in a multidisciplinary team. It is obvious for all of us, but not in the rest of Argentine. In this clinical case, many medical specialists intervene to treat that patient. And the second is to remark that the biology does matter, even in a small tumor less than 1 centimeter. This is a patient that needs chemotherapy because she had a high risk to recurrence. It is not only the anatomic parameters, the tumor site, the axillary node, but also the biology is so important, even in luminal tumors.
Yeah, I fully agree. If I can just add a comment on the multidisciplinary part. In my practice, something it's very, very useful is to have these oncofertility units. So this, which actually is a gynecologist doing the fertility part, but this person is also specialized into the management of all other gynecological related issues that this patient may have. So contraception, maybe hot flashes, sexual dysfunction. So if you have this contact with a gynecologist that he used to see patient with cancer that cannot receive hormones and patient with breast cancer that cannot receive hormones, I think it's very useful also this multidisciplinary management, not just for the fertility part, but also for the side effect of OFS and so on. So I always try to advocate for this contact with fertility specialists, which can be outside your institution if you don't have in your institution, but it's very useful to me as well, because when the patient have this toxicity, I can say, okay, I'm gonna refer to this other colleague, and then I'm gonna focus maybe on other issues in the little time we have during the consultation. So yeah, the multidisciplinary part in these young women is critical.
Thank you so much. Thank you. So our last case comes from this institution and is going to be presented by Francisca.
The case I'm presenting is changes in HR status. I'm Francisca Quiroga. I'm a fellow of the Breast and Gynecology Oncology Surgical Unit here in the hospital. Okay. We have a 40-year-old female with no family history that her story starts in March 2023 with a lump in her left breast of 2 centimeters. In the imaging studies, we found a solid nodule measuring 23 millimeters and at least 5 suspicious adenopathies by RADS5. We underwent a core biopsy of the breast and axilla. In the breast, we have an invasive breast carcinoma, known otherwise specified, G3, and with hormone receptors negative, HER2 negative, and a KY65, 60%. In the lymph node, we have the same immunochemistry. In the CT scan and bone scan, we have no metastatic illness, and we made a 31 gene panel testing with no mutations. So she initiated neoadjuvant treatment with Keynote 522 scheme and ovarian function suppression with Goserelin. She started in May and ended in August 23. She received 12 cycles of weekly carboplatin paclitaxel, 4 cycles of pembrolizumab, and 1 cycle of AC doses, and had to interrupt this treatment because she had very clinical complications, require a long hospital stay. Febrile neutropenia with pneumocystis jirovecii, pulmonary embolism, and right upper limb cellulitis. Therefore, she underwent surgery. The surgery was in December 2023. She underwent a left lumpectomy and axillary lymphadenectomy, and the pathology reports shows an infiltrated carcinoma known otherwise specified, with a tumor size of 1.5 centimeters, G1, clear margins, lymphovascular invasive negative, and the receptors were the estrogen receptor 60% and the progesterone receptor 20%. The HER2 status were negative, and the axillary lymph nodes, we only found one node with micrometastasis. So the residual cancer burden classified class 2. Okay, to sum up, we have a 40 years old patient with a triple negative breast cancer, stage 3, with no mutations, that she underwent a keynote scheme, but only with one cycle of anthracyclines and cyclophosphamide because of the most adverse events that she had that require a hospital stay. So she underwent surgery, and the pathology shows this change in the hormone receptors. So the questions are, first, which is the preferred hormonal therapy strategy? Ovarian suppression, tamoxifen.
So this was, I mean, this is a very challenging case, right? And we have had a lot of discussion regarding how to manage the adjuvant phase of this patient. So it's a premenopausal women with, I mean, when she went direct from cycle 1 AC to surgery because, I mean, she was not able to tolerate more chemo. I mean, she was not fully recovered from the pneumonia and all the things that she had. So she had the surgery, and then the pathological report turned out that it was that there were some expression of estrogen receptor. So we think that she might benefit from a hormonal blockade somehow, and so we were discussing if she needs ovarian suppression with tamoxifen, with AI, or I don't know what to do with this. I mean, she got goserelin during chemo, so she was suppressed. Like her ovaries were suppressed.
This is very complicated, so I'm not sure. No, yeah, well, first I will ask the pathologist maybe to look at the biopsy diagnosis if it was triple negative in all.
We did that. You wanna show all the questions? So yeah, so that's the last question is so maybe Mariela, she doesn't want to talk. You can do it in Spanish and we translate.
I'm Italian, I can understand if you speak slowly.
Yes. Is there anyone? Let's in Spanish.
Buenas tardes a todos. Sí, lo primero que hicimos fue, obviamente, que estos cambios en el estado de los receptores hormonales están descritos y en este grupo de los carcinomas triple negativos es una discordancia muy poco frecuente que no supera el 5% en este grupo. Y habitualmente lo que hacemos, lo primero es revisar la biopsia previa y ver que no haya un error, que los controles estén ok. Y esto fue lo que se hizo, se revisó y en ambos casos, tanto en la core biopsy de la mama como de la lesión, fue un carcinoma triple negativo con buenos controles.
So
yes, I got it. Yeah.
You got it.
I got it. Yeah.
Anyone needs translation?
Yeah, well, I think that the difficult part here on the endocrine therapy part is that what you see is a grade 1 lumina-like tumor. So, well, the first question I will give OFS. So in the doubt, I will give OFS. Then between TAM AI, again, not a big preference there. I will start probably AI, and then if not tolerated, I will go for tamoxifen. The other are really more complicated. No, probably the second, I will stop Pembro. I don't know if you had the same, but we had so many toxicities. Very weird, very complicated, a lot of inpatients, a lot of, so that if I have a reason to stop it, I'm okay to do it. So in this case, I will probably consider, she had a lot of complication, probably more for the anthracycline part than the Pembro, but still she had a lot of important complications, so I will probably stop the Pembro part later on. The CDK, this one I'm not sure.
You don't. So in the real life, she was not. I mean, we don't have Drivo, so that's one option that is out of the table because we don't have it, and she was not able to tolerate Abema because of her state. So at the beginning.
Thanks, thank you for simplifying that, and it's fine not to give any.
The patient simplified a bit the decision. In fact, what we did it was we reintroduced Pembro with hormone therapy. Is right? Am I right? Yeah. With hormone therapy, and we wait till some clinical recovery to introduce capecitabine, and after the 6 months of capecitabine, we'll see how in which situation she is, and we might consider, sequentially treat her with abemaciclib. That was our plan. We don't know exactly what to do.
Yeah, it's so complicated that almost all these choices will make sense at some point. All this treatment that you are saying may be a over treatment, because you don't know if the residual disease, which is a grade 1 lumina-like tumor, is this a triple negative tumor? So do you need really capecitabine plus Pembro there?
Oh, we don't know.
Not sure. And then if it's the luminal-like, it's really only this micrometastasis, then not even Abema.
Well, you got chemo. I mean, is it?
Yeah, but
again,
it's no. Yeah.
I would like to go back again to Mariela. Is this grade 1? I mean, which is the biological explanation that you might? I mean, of course, nobody knows. But what do you think? I mean, the chemo might have erased a triple negative component and leave a luminal A component with no response. May the chemo make change the luminal from A to B, from B to A, because that might happen. We have many studies showing that the intrinsic subtypes change over treatment. So, for me, it's really hard to believe that this is a real luminal A, because I mean the situation. I mean, this is not a newly diagnosed patient, so this has been gone through the pressure of treatment. So I don't know. I mean, that's why we choose this case, because I mean we got struggle here and we don't know exactly what. I don't know. ¿Quieres hacer un
Option 1. I think que el tratamiento de quimioterapia justamente trató ese gran grupo, gran extensión del tumor que era de alto grado, porque así se veía en la biopsia original, y seleccionó la lesión residual que es G1 y que tiene esas características.
Okay.
But probably you cannot exclude that this luminal case was a luminal B that turned to be a luminal A-like tumor based, following the pressure of treatment, even though the chemo part was not so much, because she received only the taxane carbo and then 1 cycle of anthracycline. So yeah, for the Pembro part, I mean, you have now the data also in the luminal, like the keynote 756. well, the other trial in the Lumina in patient with grade 3 tumors.
The 7FL and the keynote 589 or something.
756 or something. But yeah, I mean, you have the same design. So in theory, yes, you have for all the treatment, probably the Pembro part, if it's the one.
In the Coraline, you have a neoadjuvant ribociclib, and they change the luminal B to luminal A.
CDK.
I think that this is a very relevant question. And I would like to ask you, what would you do in the opposite case? We had the 7FL trial, and a patient of mine received the Nivo chemoadjuvant treatment for the neoadjuvant setting. She had first a luminal B tumor, and after surgery, the residual tumor was a triple negative. So we decided to discontinue her for the trial and give her capecitabine. But what would be your approach?
I agree. I will have give capecitabine, and then I will still go for endocrine therapy because she was a luminal tumor earlier on, but I will give capecitabine, yes.
And what about the CDK4/6 inhibitors?
In that case, we prefer not to give her the CDK4/6 inhibitor because the patient had another complication that was that in the surgery, the lymph nodes that were dissected were diagnosed as a T lymphoma, which was very shocking for us and was considered to be later after several other tests were done as a lymphocyte reaction to immunotherapy. So a lot of time passed and we decided not to give her CDK4/6 inhibitors because we didn't have enough evidence. It was like 2 years after that we had to start the endocrine therapy part.
Great. Thank you. Thank you, Francisca. I want to especially thank you, Mateo, for this space. We are done. No more cases. And I really thank you to all the people coming from other institutions. We have a present for you.
It's the Boca T-shirt for it.
I didn't get it. So at this moment, I expected to have the Argentinian T-shirt with the Messi name and the 10, but Adidas didn't deliver on time, and I got them on the phone, and the residents hear me that I was really upset with them. They say that I was unrespectful, but I think that it was the other way around. So so that shirt is for you, and you will get it. If it's, he's leaving on Thursday, so if it arrives, you will get it this time. Otherwise, at ASCO, you have the T-shirt.
Thanks. Thanks for having me. Thank you very much.
And I hope everyone felt comfortable and welcomed. Thank you again. We have a lunch next door and a picture. Okay, we will take a picture here. Yes, los bombones are coming. ¿Dónde están? Ah, sí, bueno. Sacarla de acá y se... Ok. La esperamos a Virginia. Okay, we'll take a picture, but we are... De los regalos. No, vamos a sacar así. ¿Sentados? No sé. ¿Cómo entro? ¿Cómo entramos? No, pues esto se cae. No, esto se cae. Todos contra acá. Bueno.
Faltaron dos. Claro, necesarias tanta circulación para ahorrar.
Los de allá, ustedes de allá.
¿Qué querés hacer?
Thank you.
Bueno.
Primero, te quiero hacer una pregunta a
Gracias.
porque no puedo las dos. No vas a escuchar. No puedo las dos.
Sí, ya está. Ya avisé, ya avisé. Es rara esta foto, pero bueno. Es rara la foto. Tienen una foto.
Pero está.
Paremos, ¿no?
Yo pongo, ahí está.
Nos ponemos acá. You in the middle.
Gracias, Fede, por venir. Estoy eternamente agradecida.
¿Vas? ¿Dónde está? Carlos. Ceci. Ernesto. No sos tímido, no sos tímido. Ven. Vení al lado de Mateo. Ahí bien.
Carlos.
Bien a eso. Una sonrisa. Ahora miren a eso, por favor. Miren los bombones. Thanks. Yes, yes, of course.
No, podés